Assalamu alaikum. Now, I would like to discuss about the thyroid part of endocrinology. USMLE inner circle note. Start with my intro along with a murmur. Listen to this. Okay, now hyperthyroidism. How to evaluate a patient with hyperthyroidism? First of all, if patient comes with hyperthyroidism, what are the investigation we will give to find out he has hyperthyroidism? First of all, we see the features, clinical features, then we suspect, and we give these three: TSH, FT4, and FT3. If TSH is low and FT3, FT4 is high, that is primary hyperthyroidism. If TSH is low and FT3, FT4 is high, that is primary hyperthyroidism. And for secondary, TSH has to be high and FT4, FT3 has to be high too. And if you like hypothalamus, remember this uh, sequence: hypothalamus, pituitary, and the target organ like thyroid. So if both of them are high, like TSH is high, FT3, FT4 is high, so problem is in the pituitary. So do the MRI of the pituitary gland. And if the problem is in the thyroid gland, then you have to look for, as it is primary hyperthyroidism, look for the signs of the Graves' disease. What are those? Goiter and ophthalmopathy. Goiter and ophthalmopathy. If it is present, then it is Graves' disease. If no signs of Graves' disease, no, then you should do either radiooptic iodine with scan, radiooptic iodine with scan, ultrasound scan. If radiooptic iodine, if radioactive iodine uptake is high, then it is, and it is diffuse pattern, think about the Graves. If it is nodular pattern, think about either toxic adenoma and or multinodular goiter. If radioiodine uptake is low, measure for serum thyroglobulin. Measure for serum thyroglobulin. If it is high, if serum thyroglobulin is high, then it is either thyroiditis or iodine exposure. It is either thyroiditis or iodine exposure. If it is low, then it may be due to exogenous hormone. If thyroglobulin is low, then it is exogenous hormone. So I am telling it in a short manner, like if TSH is low and FT3, FT4 is high, then it is primary hypothyroidism. Then you have to look for signs of the Graves' disease. If signs of the Graves' disease is present, uh, signs of the Graves' ophthalmopathy is present, then it is Graves. If no signs of the Graves ophthalmopathy or Graves disease, then you should do radioactive uptake. If radioactive uptake show increase scan increase uptake, high uptake, then high uptake and diffuse uptake, then it is Graves disease. If it is nodular uptake, nodular pattern uptake, then it is toxic adenoma or multinodular goiter. And if a radial uptake is low, then measure serum thyroglobulin. If serum thyroglobulin is high, uh, then either it is thyroiditis or iron exposure. If it is low, then it is exogenous thyroid hormone, exogenous hormone. Okay. And then management of the postpartum thyroiditis. In postpartum thyroiditis, how will you confirm the diagnosis? T3, T4 is high, TSH is low, thyroglobulin is low, radiation uptake is decreased, radiation uptake is decreased, and positive TPO antibody and negative TRAB, positive TPO antibody and negative TRAB. So postpartum thyroiditis, T3, T4 is high, thyroglobulin is high, TSH is low, radiation uptake is low, and positive anti-TPO antibody and negative TRAB. This trap for Graves. Okay. If hyperthyroid phase like T3 T4 is high, TSH is low, then give beta blocker for symptom control. Give beta blocker for symptom control. If hypothyroid phase T3 T4 low, TSH is high, breastfeeding or attempting pregnancy, and hypothyroid symptoms, and TSH is high more than 6 months, give levothyroxine. So breastfeeding, attempting pregnancy, hypothyroid symptoms, and TSH is high for more than 6 months, go for levothyroxine. If it is euthyroid phase, normal everything, when wean off levothyroxine and tolerated an annual TSH measurement. Okay, then evaluation of thyroid nodule. If you find a patient having thyroid nodule, what you will do next? You will give a TSH and you will do ultrasound. So TSH level and ultrasound. If TSH level is normal or elevated, consider FNA based. Consider fine needle aspiration based on size and ultrasound finding. Consider fine needle aspiration based on size and ultrasound finding. If it is if the thyroid nodule is low, what you will do next? You will do radio frequency scintigraphy, radio iodine scintigraphy. If radio iodine scintigraphy show hypofunctional or cold nodule, then you need to consider FNA based on the size and ultrasound finding. If radioscintigraphy shows hyperfunctioning hot nodule, treat for hyperthyroidism. If hyperfunctioning hot nodule, treat for hypothyroidism. If it is hypofunctioning cold nodule, cold is always bad. Some cold-blooded murder happened in the nearby area, so cold is always bad. And for cold, you need to look for carcinoma. Now, hyperthyroid bone disease. If there is excess thyroid hormone, if hyperthyroid, that means there is excess thyroid hormone. Excess thyroid hormone increases osteoclastic activity, increase bone resorption, increase fracture risk, increase bone resorption, increase fracture risk, and decrease bone density. As it increases the osteoclastic activity, so it increase bone resorption, it increase fracture risk, and decrease bone density. If it is hypercalcemia, if hypercalcemia, decrease renal calcium reabsorption, decrease renal calcium reabsorption. In hypercalcemia, there is decreased PTH secretion, decreased renal calcium reabsorption, and there is hypercalciuria and net calcium wasting. And in hypercalcemia, there is decreased PTH. Decreased PTH will decrease conversion of 25 hydroxyvitamin D to 125 hydroxyvitamin D. Decreased PTH will convert 25 hydroxyvitamin D to 125 and increase catabolism of 125 hydroxyvitamin D and increase catabolism of 125 hydroxyvitamin D. Uh, decrease calcium, if there is decreased calcium absorption and decrease GI calcium absorption and decrease renal calcium reabsorption, it will further causing hypercalciuria and net calcium wasting. So main thing in here, we need to remember, like in hypercalcemia, when there is hypercalcemia, so high calcium, decreased PTH, which will increase the loss of the calcium in the form of urine. So hypercalciuria and net calcium wasting. That's because a low pTH will decrease renal calcium absorption and and decrease GI calcium absorption and decrease renal calcium reabsorption. Okay, and now Graves' disease. In Graves' disease, antithyroid drug can induce remission in many patients, may be used as pre-treatment prior to radioactive iodine or thyroidectomy. Radioactive iodine, uh, acceptable option for moderate hyperthyroidism, may initially worsen ophthalmopathy and hyperthyroid symptoms leads to permanent hypothyroidism over time. Thyroidectomy preferred in patients with very large goiter, obstructive symptoms, or ophthalmopathy or cancer. Preferred in patients with very large goiter, obstructive symptoms, ophthalmopathy or cancer. Okay, after initiating antithyroid pharmacologic therapy for Graves' disease, frequent monitoring of the thyroid hormone is necessary to ensure correct dosing. Once the thyroxine concentration has established, the patient is euthyroid and the dose of propylthiouracil can be decreased. Once the thyroxine concentration has been established, the patient is euthyroid, then propylthiouracil should be decreased 30 to 50%. If it is not decreased, secondary hypothyroidism may develop. Serum total T3 and free T4. Serum total T3 and free T4 are used to assess for thyroid function during treatment with antithyroid drugs. And TSH remains suppressed for several months following initiation of the therapy and does not reliably reflect thyroid functional state during this time. So TSH may remain suppressed for several months following initiation of the therapy and does not reliably reflect the thyroid functional status during this time. So treatment options for Graves' hyperthyroidism: antithyroid for mild, for older age, preparation for radioiodinic or thyroidectomy, and pregnancy. PTO is the first trimester, then you can add methimazole. Radioiodinic moderate or moderate to severe with or without ophthalmopathy. Patient's preference with mild hyperthyroidism and thyroid with very large goiter, suspicion of thyroid cancer, coexisting with primary hypothyroidism, pregnancy, who cannot tolerate the thiamines, severe ophthalmopathy, retrosternal goiter with obstructive symptoms. Radioiodine uptake contraindicated in patients with severe ophthalmopathy due to increased thyroid stimulating immunoglobulin titer, glucocorticoid, and antithyroid may be given initially. What is the most common complication of radioiodine uptake? Radioiodine uptake when treating with thyroid disease, permanent hypothyroidism, the dose needed for treatment, as well as diffuse uptake of iodine in Graves' disease results in permanent hypothyroidism more than 90% of the cases. In contrast, when radioiodine uptake is used to treat toxic nodular goiter or adenoma, the radioisotope is taken only by the autonomous thyroid tissue, and the function of the remaining normal tissue is usually adequate to prevent permanent hypothyroidism. But sometimes radioactive iodine intake is used to treat toxic nodular goiter and toxic adenoma. When it is used in toxic adenoma or toxic nodular goiter, in their autonomous thyroid tissue only take radioisotope. That's why the normal tissue uh, remains intact, so it prevents permanent hypothyroidism. The most important clinical features of thyroidism, very important. It can be happening in thyroid and non-thyroidal surgery. It can be acute illness. It can acute illness, trauma, infection, childbirth. It can happen in acute illness, trauma, infection, childbirth, and acute iodine load. High fever, tachycardia, hypertension, congestive heart failure, cardiac arrhythmia, atrial fibrillation, agitation, delirium, seizure, coma, goiter, lead lag, tremor, nausea, vomiting, and diarrhea. Thyrotoxicosis with normal radioiodine uptake. Thyrotoxicosis, normal radioiodine uptake. It is GTT, Graves, toxic adenoma, toxic multinodular goiter. And the thyrotoxicosis with decreased radioiodine uptake. It may be painless thyroiditis, painless or silent thyroiditis, subacute thyroid recurrence, autoimmune thyroiditis. I excessive dose of levothyroxine, stroma ovary iodine induced, extensive thyroid cancer metastasis, painless thyroiditis is associated with thyroid peroxidase antibodies and is considered with and is considered a variant of chronic lymphocytic Hashimoto thyroiditis. Okay, features of Graves' disease in eye, lid lag, lid retraction, diplopia in skin. There may be hair loss, pretty well mixed between heart. There may be target hypertension, atrial fibrillation, nail. There may be onycholysis, clubbing. In endocrine, there may be hyperglycemia, hypercalcemia, bone loss, menstrual irregularity. In GI, there may be diarrhea, neurological tremor, hyperplexia, proximal muscle weakness can happen. Clinical feature of thyrotoxicosis in older patient. In older patient, cardiovascular feature, atrial fibrillation, tachycardia, hypertension, heart failure can present with heart failure, neurologic like apathy, confusion, tremor, proximal muscle weakness, and endocrine proptosis, lead lag, hydromegaly, and GI decreased appetite and constipation. What is the likely diagnosis in patient that develops post-operative high fever, tachycardia, lead lag, hypertension, no muscle rigidity. CK is elevated, no muscle rigidity. CK is elevated. This is thyroid storm. Typically triggered by an event in patients with undiagnosed or inadequately treated hyperthyroidism, surgery, trauma, infection, CT scan with contrast due to acute iodine load. Another differential is pheochromocytoma will have no fever. Pheochromocytoma will have no fever. Episodes of pheochromocytoma can be precipitated by medication, especially anesthetic agents and surgical procedures. Also called malignant hyperthermia, looks for similar symptoms but elevated CK, hyperkalemia, and muscle rigidity. Gestational transient thyrotoxicosis. In gestational transient thyrotoxicosis, thyroid changes in the pregnancy increase thyroid hormone demand in the pregnancy. Estrogen increase the TBG and increase T3, T4. Estrogen increase the TBG, increase T3, T4, and HCG thyroid follicles. HCG thyroid follicles for increased T3 and T4 production with feedback suppression of the TSH. First trimester zero point 0.1 to 2.5, second trimester 2 to 3, third trimester 3.3 to 3. First trimester zero point 0.1 to 2.5, second trimester zero point 0.2 to 3, and third is zero point 0.3 to 3. Check free T4, total T4. If TSH is significantly suppressed less than 0.01, then you should give management in pregnancy. Evaluation of hyperthyroidism in pregnancy starts with measuring free T4 level. Free T4 level, it is the reliable marker in pregnancy. Free T4 is a reliable marker. TSH is recommended at the initial test in pregnant patient with suspected hyperthyroidism. If TSH is suppressed below trimester specific norms, free or total T4 is used for confirmation. If TSH is suppressed but T4 is normal or equivocal, total T3 may be useful. What is the treatment of hypo or hyperthyroidism? What is the treatment of hypo or hyperthyroidism in pregnancy? Hyperthyroidism, PTU, first time is a methimazole, second and third hypo is levothyroxine. Monitor, monitor weekly, 4 weeks. As pregnancy increase TBG, it will increase the L-thyroxine requirement. Monitor uh, 4 weeks. As pregnancy increases the TBG, it will increase the levothyroxine. Over treatment with maternal hyperthyroidism can cause fetal hypothyroidism quite and may be titrated to maintain a mild hyperthyroid state. So hypothyroidism in pregnancy, stimulation of the TSH receptor by beta hCG, feedback suppression, increased circulating, total 3334. Pre-pregnancy management, optimize levothyroxine dose to maintain TSH in normal range. Pregnancy management, levothyroxine dose should be increased 30% of positive pregnancy test. Measure TSH every 4 weeks and adjust levothyroxine dose to trimester specific TSH norms. What is the recommended management for a patient with a medically managed hypothyroidism? Medically managed hypothyroidism that desires to be pregnant, increase levothyroxine dose at the time pregnancy is detected. During pregnancy, HCG directly stimulates TSH receptor on the thyroid follicle and increase the release of the thyroid hormone. Okay, now very high HCG, multiple gestation hyperemesis can multiple very high HCG, multiple gestation hyperemesis gravidarum can cause gestational transient thyrotoxicosis. This condition is self-limited and resolves as HCG falls with 14 to 16 weeks of gestation. As HCG falls within 14 to 16 weeks of gestation, then these transient thyrotoxicosis will fall. Because of the severity of the hyperemesis correlates with the HCG, continued clinical hyperthyroidism after the resolution of the vomiting may warrant additional investigation. This is the thyroid disease during pregnancy. In normal, TSH level is zero point 0.1 to 4. TSH level is 0.1 to 4. Free T4, no change, and total T4 is increased. And in hyperthyroidism, total T4 is increased, but hypo it is variable. But free one, Free one, it has no change, or subclinical, it has no change, subclinical or slightly higher at this. And so you have to look at the level. If it is TSH is below zero point 0.1, so it is hyperthyroidism. If TSH is more than 4, then it is hypothyroidism. Okay, then the hypothyroidism, three types of hypothyroiditis: chronic autoimmune thyroiditis, Hashimoto thyroiditis. In here, predominant hypothyroid feature, diffuse goiter, positive T antibody, so positive TPO antibody, and variable radioadrenoptic. Painless thyroiditis, a silent thyroiditis, there may be a variant. Chronic autoimmune thyroiditis, it may be small non-tender goiter, spontaneous recovery. In here there may be positive TPO, but low radioadrenoptic, not variable radioadrenoptic like chronic autoimmune thyroiditis. And subacute decurvence thyroiditis, this is the only thyroid which is painful, comes with a fever, hyper, initially maybe comes with hyperthyroid feature, then it may comes with hypothyroid feature, and likely post-viral inflammatory procedure, elevated ESR, CRP, low radioadrenoptic. Painless thyroiditis, often a self-limited hyperthyroid phase of painless thyroiditis is self-limited hyperthyroid phase of Hashimoto thyroiditis, hence the anti-TB antibody is positive. Okay, what is the likely diagnosis in a patient with a long history of Hashimoto? Long history of Hashimoto thyroiditis develops rapidly enlarging firm goiter, long-standing Hashimoto, rapidly enlarging firm goiter, dysphagia, hoarseness, fever. Think about thyroid lymphoma. May also have facial plethora, cyanosis, facial plethora when raising the arm above the head due to compression of the subclavian vein. Raising the arm above the head, raising the arm above the head due to compression of the subclavian and the internal jugular vein between the clavicle and the thyroid, which is called Pemberton sign. This facial plethora and cyanosis may be seen in thyroid lymphoma. Okay, levothyroxine replacement, very high yield. Initial standard dose is 75 to 125 microgram per day. Elderly heart disease 25 to 50. You have to start with 25 to 50. Dose adjustment increase every 6 weeks until TSH is within the normal range. Increase every 6 weeks until, and monitor TS every 6 to 12 months. Condition requiring for higher doses like malabsorption, if celiac disease, if the drug interfering with absorption, iron, calcium, drug that increases thyroid metabolism, phenytoin, carbamazepine, rifampin, increases the thyroid metabolism, so higher doses is needed, and obesity, pregnancy, and overt proteinuria. Now subclinical hypothyroidism. In subclinical hypothyroidism, elevated TSH, normal T4, elevated TSH, but normal Phe T4, mild symptoms. If TSH is more than high, when we need treatment for subclinical hypothyroidism, elevated TSH, if TSH is more than 10, if TSH is 7 to 9.9, age less than 70, treat. Age more less than 70, treat. Age more than 70, treat. If convincing hypothyroid symptom, TSH upper limit 6.9, upper limit of the normal 6.9. If age less than 70, treat. And if it is more than 70, do not treat. Possible harm. Age. Okay, subclinical hypothyroidism, very high yield. Subclinical hypothyroidism, if TSH is high, more than 10, treat with levothyroxine. Subclinical hypothyroidism, where TSH is high, T4 is normal. If TSH is less than 10, but the upper limit of the normal, positive anti-TP antibody, yes, treat. No, pain with patient with the following: goiter, symptomatic pregnancy, over hypercholesterolemia, if these features are present: goiter, symptomatic pregnancy, ovulatory dysfunction with infertility, and hypercholesterolemia, yes, treat with levodopa. No, routine monitoring. What pregnancy complication may associated with subclinical hypothyroidism? Miscarriage can happen with subclinical hypothyroidism due to high titer of anti-TP antibody, increased risk in both euthyroid and hypothyroid women, increased risk in both euthyroid and antithyroid. The American Thyroid Association, ATA, American Thyroid Association, recommends all individual over the age 40 to be screened for thyroid function. All individual level, and American College of Physician, women over 50 with findings suggested thyroid disease should go for. And then euthyroid 6 syndrome. In euthyroid 6 syndrome, there are early or mild cases. T4 is low, T3 is low, T4 is normal, and TSH is normal. And reverse T3 is raised. In reverse T3 is always elevated in euthyroid 6 syndrome, but in prolonged or severe, all the T3, T4, and TSH is low. In euthyroid 6 syndrome, in early or mild cases, T3 is low, T4 normal, TSH normal. Low T4 is thought to be the result of decreased peripheral conversion of a decreased peripheral conversion of T4 to low T3 is a decreased peripheral conversion. Euthyroid 6 syndrome, transient central hypothyroid state that function minimize amyloid catabolism. In severe illness, treatment not recommended unless abnormal thyroid function persists after the patient has returned to the baseline. Reverse T3 is primarily used in patients with low TSH, in patients with low TSH to differentiate central hypothyroidism from euthyroid 6 syndrome. In central hypothyroidism, low T4 which leads to low T4 which leads to low T3. But in euthyroid 6 syndrome, there is high reverse T3. Low in euthyroid 6 syndrome, T4 may be low, but reverse T3 is higher. Reverse T3 is higher. Factors that suppress the conversion of T4 to T3, caloric deprivation, increased glucocorticoid and inflammatory cytokine, tumor necrosis factor, interferon alpha level, and elevated free fatty acid level. That's all about the thyroid part of my journey. Oh, okay, and the murmur is, can you tell me the name of the murmur? Uh, do you want to hear the murmur again? Okay, it is aortic stenosis. Uh, Thanks for watching my video. Hope you will like my video and share to your friends.